All right. A couple cases of aortic dissection, and I decided not to kill you with this is a intramural hematoma, this is a penetrating ulcer, etc. They're all pretty much treated equally in terms of their risk, and so I don't see too much importance about making those distinctions. What I do think is important is looking for the complications of these dissections, because that's where people really go south, right? So here is the flap, and there's a little fenestration within it, which explains why there is an equal amount of contrast in both the true and the false lumens here. Right, and here it is at the aortic root with another fenestration. And there's clear enlargement of the root. And then here, you can see it's actually breaking out. That's from the false lumen. The wall is weakened and is extravasating into the pericardium. So that is a common dreaded complication. Look at that hemopericardium with active swirling. You can get some really weird patterns of extravasation that sometimes will mimic vessels and all kinds of crazy things, but it's really just the actively extravasated contrast winding its way, burrowing through a relatively soft kind of semi-acute plot. I will tell you, making this diagnosis is important, but ultimately, a lot of these people don't survive. When I was an internist in the ICU, we actually witnessed to a fully lined patient. She came in with a known dissection, and then all of a sudden everything tanked, right? Her heart rate went way up, her A-line pressure just went way down, and we knew this was tamponade. So we actually had the echo lady was there doing an echo on the adjacent room. And we grabbed her and said, can you just put the transducer on here and show us a big hemopericardium? And she did, huge hemopericardium. And I got a huge syringe with a big 18, 16 gauge needle and sucked it all out, 100 cc's at a time. And it was quite a moment, right? Her heart rate returned to normal, her pressure came up, everybody in the room cheered, and it lasted about 15 or 20 seconds, and it just filled back up again. And I started pulling it again, and I remember the attending saying to me, "You just going to do that until you get all 5 liters?" Because there really wasn't any way to fix it in a timely fashion. So it's a devastating complication, but that is an aortic dissection with decompression into the pericardium, hemopericardium, and tamponade. And I think you'll see the hepatic venous reflux in this patient as well. It's almost always going to be present. So there's that swirling extravasation within the clot that's in the pericardium, and there is your IVC and hepatic venous backflow related to the increased right-sided pressures. A nice aortic dissection. And this one was complicated further, as if this patient didn't have enough problems. Note that pneumomediastinum surrounding the vessels here at the thoracic inlet, and this was a botched intubation. You can actually see the balloon has disrupted that posterior tracheal membrane. I always used to make far too certain of the cuff inflation, and I'm lucky that this never happened to me. But that cuff can definitely be overinflated, and you can see the gap it's caused. And here you can see the extent of the pneumomediastinum that resulted. And this doesn't just go away on its own. Typically, they'll put a covered stent in order to let those heal. All right, aortic dissection with many a mishap. There's another aortic dissection. There is the flap, but note its passage across the left coronary origin. See on the patient's left, that flap is going right over the origin of the coronary artery. And this is another dread complication. Incidental finding here is yes, there is left atrial appendage thrombosis. Important to note in other situations, but this is not one of them. So you can see there's actually no filling. There's the left main coronary, the circumflex, and the LAD all show no contrast enhancement. They actually fill retrograde a little more distally on the cine. But note this, there is normal enhancement of the basal myocardium, the portion supplied by the right coronary. But the whole anterior wall, the lateral wall of the myocardium are all hypodense, non-enhancing because of the deprivation of blood flow. So actually seeing the infarct that's occurring, pretty amazing case here, I think. So there's the dissection, and watch that left side, it goes right there, right across the coronary artery origin. And then only later do you see any contrast in the circ or the LAD. And there is the differential and enhancement of that left ventricle. All right, I think I've got the coronals, yep. So here is the flap, and that's above the level of the aortic valve. It almost looks like aortic valve, a bizarre one, but it's too high. And there is that left main failing to fill. And then, of course, that myocardium, you can really see the basal myocardium is enhancing, while the anterior and lateral walls are not. So there's that flap. And the normal basal myocardium. All right, so that's an aortic dissection with coronary occlusion. This is from my pediatric collection, but I thought it was worth stressing this fact. When you get a history of Marfan syndrome, make sure they do that study with contrast, just as a starter. I've seen a few come in where they say, oh, known aortic aneurysm, Marfan syndrome, chest pain, and they do a non-contrast study, which is, I think, just crazy. You know, it's failing to acknowledge the obvious complication you're looking for. These guys get aortic aneurysms, but they also are particularly inclined, because of the lack of integrity of their soft tissues in general, to get aortic dissections. So as far as I'm concerned, when you get a history of Marfan's and you see a big ascending aortic aneurysm, you have to look for the dissection until you find it, because you know it's there. So huge dilated root, nice flap here. Note also the asymmetry of the chest. I have definitely noticed the ribs in Marfan's patients are rarely normal. And if you look on the cine, you'll see these have a funny acute angle to them at the anterior lateral aspect. And that's resulting in sort of an off-kilter sternum as well. So it's not uncommon to see some chest wall deformity in Marfan's patients. So there's part of the flap, and there's another part of the flap. And note again those rib and sternal deformities. All right, so that is a Marfan syndrome with an acute aortic dissection. See that little flap anteriorly that we went by? They can be really, really subtle. All right, this is a wild one. In all my years, it's the only one I've seen. We don't know exactly why this happened. We wonder if it might have been a long-standing indwelling nasogastric tube. But this patient actually has vascular contrast in the esophagus. There's an NG tube there, and there's a little tiny communication right there between the aorta and the esophagus. This is obviously an acute concern. So you have to know, of course, that the patient didn't get oral contrast, but aside from that, that ought to really strike your eye. You can see it's segmental too. It's just right above the area where there's that communication. A little bit of contrast got down into the stomach there. So that is a highly unusual aortoesophageal fistula, and we think maybe related to the nasogastric tube. That tube had been in for a couple of weeks, was the report from the clinicians, and they did not have any other reason to pin this on. All right, aortoesophageal fistula. This one's pretty straightforward, but it's something it's nice to have seen, and so you can identify it easily. There's a rounded contrast collection here, just anterior to the LAE, and distorting the adjacent main pulmonary artery. And it's arising from the bifurcation of the left main, which you can see is very atherosclerotic. So most of the aneurysms that you see in the coronary arteries are due to manipulation, right? Certainly venous grafts have a tendency to form these aneurysms, but just this vessel ruptured and formed sort of a pseudoaneurysm right north there of that atherosclerotic bifurcation of the coronary. So this is a naturally occurring left anterior descending or left main coronary aneurysm, which is relatively uncommon. All right, an atrial myxoma. This was in my board review. This is only worth 100 points, folks. It's pretty easy. But you've got a fat density mass in the left atrium. They are almost always pedunculated and almost always arising from the interatrial septum. This has led to more misdiagnoses than I care to imagine, because something that's far more common is benign fatty infiltration of the interatrial septum. Okay, there is no reason that you should mistake these two. Benign fatty infiltration of the septum can be dramatic. It can look like a mass. In fact, I have cases that it looks like it's actually compressing the SVC and limiting venous return. But for whatever reason, it can look dramatic on a scan and yet still be physiologically utterly inert, totally benign. But in the case of septal fat, it clearly is confined to the septum. It usually takes a little bend towards the right side of the heart, and it's not going to be an intraluminal mass. It looks positively sessile. And so I don't think these two should be confused, but I do see it all the time. In fact, to the point where when I read someone reporting an atrial myxoma, I roll my eyes and think it's going to be septal fat, right? These are pretty uncommon tumors. But again, they have a very characteristic appearance. They arise from the left aspect of the interatrial septum. They're pedunculated and fully intraluminal and fat density. You can get these with little calcifications in them. Don't let that dissuade you as to the diagnosis. The thing I love about this picture, it was always one of my favorite visuals from internal medicine. Harrison's internal medicine talks about how pedunculated myxomas can cause wrecking ball damage to the mitral valve with every atrial contraction. And I always thought that was great. And you can really see it here. This thing is herniating down through the mitral valve. And obviously, if it's doing that with every atrial contraction, the pounding that the mitral valve can take is daunting. And so that's why, of course, these are also one of your causes for cardiac source of stroke, right? That these can in fact cause clot to form, and then obviously it's left-sided, so it can result in a stroke or an infarct. You can see the LAE was enlarged as well, which is common. These obviously cause at least some degree of obstruction in the mitral valve, so you'll get left atrial enlargement and left atrial appendage enlargement as well. All right, atrial myxoma. Sorry, I was saying LAE, that's left atrial enlargement. Left atrial appendage, LAA is what I meant to say. All right, this one is pretty neat to see on a non-gated study, but this is fatty infiltration and thickening of the right ventricular myocardium. Compare that density to the septum. And also note the thickness, right? It's rarely that thick. The right ventricular myocardium is usually on the order of 1 or 2 millimeters thick. So this is ARVD, arrhythmogenic right ventricular dysplasia. And the treatment for these in my day was just placement of an automated defibrillator. You can see that right heart is a bit dysfunctional as well, and there's significant enlargement of the right atrium and ventricle. And you can see there's also a little bit of non-compaction. The right ventricle is always less compacted than the left, but even that is a bit much. This actually is a progressive thing. It gets worse over time, and it can ultimately even involve the left ventricular myocardium as well. I've got a few cases where there are patches of thinning and fatty infiltration in the left ventricle as well. All right, that's ARVD.